Dear audience, let me introduce my PhD topic, which is the role of alternative treatment methods in lung cancer. My name is Shahar Adar. I'm a first-year PhD student and sixth-year medical student. Together with my team, our vision is to increase the quality of life and the survival rate of patients with lung cancer, and we plan to do so by conducting a comprehensive analysis of different treatment methods in lung cancer. In my speech, I will mention two specific goals, both of them are investigating different treatment methods of the disease. My first project, investigating the safety and the efficacy of different local regional therapies in early stage non-small cell lung cancer. And I will choose the methodology of systemic review and meta-analysis to investigate this topic. A bit of a background. Every year, there are 2.2 million new cases diagnosed with lung cancer. Now, to put it into context, it means that every 13 seconds, another patient is diagnosed with the disease. Nowadays, there are three main definitive local regional therapies for the disease. We have surgery, ablation therapy, or radiation therapy. Nowadays, surgery is the gold standard of treatment, whereas ablation therapy or radiation therapy are alternative and minimally invasive techniques and are offered for those patients who cannot undergo surgery. Now, there are a few disadvantages for surgery being the gold standard. First of all, the long hospitalization time and the long rehabilitation time of surgery comparing to the alternatives is extremely high. So a patient that undergo lobectomy or segmentectomy, for example, can stay at the hospital for a week, maybe up to 10 days, whereas patients who undergo radiation therapy or ablation therapy will stay in the hospital for up to 24 hours observation time. That is why we would like to investigate whether those alternative techniques, the radiation and ablation, might have the same safety and efficacy as surgery. We conduct this clinical question: can ablation therapy or radiation therapy can serve as a viable alternative for surgical resection for patients with early stage non-small cell lung cancer? And we hypothesize that those alternatives are non-inferior to surgery. And by investigating this topic, we could provide a better personalization of the treatment for the patient. The patient will have the best treatment that they can have. We conducted this search key. It has 3 domains, and we run the search key into 3 databases. And overall, after selection process, we received 172 articles included. Now, let's talk about the results. In this first figure, you can see a Kaplan-Meier curve representing the overall survival of all of the arms in our study. We have ablation in red, surgery in green, and radiation in blue. Now, the x-axis, as you can see, represents the follow-up time from the time of the intervention. The y-axis represents the probability to survive at a specific time point. The higher the curve is, the better the survival. Now, at the table below, you can see the total number of patients at risk at specific time of the follow-up. Now, from a statistical point of view, we also included the forest plot for a specific time. Now, those forest plots are correlated and belongs to the same analysis as the Kaplan-Meier curve. So for the 12 months overall survival, so 1 year, we can see that there is no significant difference between ablation, radiation, and surgery. Whereas on the 24 months survival probability, surgery, same as you can see on the plot, has superior and best overall survival of the second 2. Our second outcome is the cancer-specific survival, which defined by the time from the treatment to an event, and the event is death by cause related by the tumor itself. We did the same analysis, and as you can see, I just want to mention the lower patient number at this analysis, and we can see that at the 12 months cancer-specific survival, there is almost no difference between all the different arms. And same goes for the 24 months overall survival. And now we have 3 more outcomes to finish analyze, and we will do that in the next week or two, and we continue with the manuscript writing. My second project, investigating the safety and efficacy of lung cryoablation and surgical resection for the definitive treatment of early stage non-small cell lung cancer. So as we said before, surgery is now the gold standard. That's what we use nowadays. However, due to the long hospitalization time and long rehabilitation time, around 15 years ago, there was a massive development and acknowledgement in the alternative techniques, specifically the ablation technique. However, there are no randomized controlled trials that compare ablation and surgery. And we would like to do so. And I would like to say a few words about a specific type of ablation technique, the so-called the cryoablation. During this procedure, the physician inserts a probe to the patient's chest in approximate to the tumor itself. Then the physician decreases the temperature of the probe itself to up to minus 60 degrees, creating the so-called the ice ball. Now, the cold temperature inside the ice ball, enclosing the tumor itself, results in shrinkage of the cell, destruction of the cellular activity and the enzymatic activity. And after a few cycles of freezing and heating inside the patient's chest, the tumor is completely destroyed. Now, a very interesting phenomenon on the cryoablation is that we can actually see the ice ball during the procedure itself in the CT device. So on picture A, you can see the peripheral lung tumor, and on picture B, you can see during the procedure the ice ball, which is circled by red. Our aim in this study is to investigate whether this lung cryoablation is as safe and as effective as surgery for patients with early stage non-small cell lung cancer. Our clinical question: can lung cryoablation provide a viable alternative to surgical resection for patients with the disease? And we hypothesize that lung cryoablation is non-inferior to surgery. And again, by investigating this topic, we would provide a better treatment personalization for the patient, so the patient will have the best treatment that they can have. I would like to summarize my talk. So we have two ongoing projects. The first one, conducted via meta-analysis, comparing between the three local regional therapies: ablation, radiation, and surgery. Whereas the second one is specifically investigate lung cryoablation and surgical resection. And for that, we will use a randomized controlled trial. I would like to finish my presentation with a quote of Patch Adams: "You treat a disease, you win, you lose, but when you treat a person, I guarantee you'll win, no matter what the outcome is." Thank you very much for your attention.
So congratulations on your presentation. It was really nice. I would like to ask a question regarding your first project. Do you have an impression about what kind of lung cancer is the one that these alternative techniques seem to be the most effective for?
Thank you for your question. Just to understand, what do you mean, like what histological types you mean?
So not the type, stage? Or what kind of non-small cell lung cancer is the one that seemed to be the most able to react to the treatment? Thank
you for your question. So we do not have any subgrouping regarding the histological type, whether if it's adenocarcinoma or squamous cell carcinoma, regarding which one is more responsive to any of the surgical or the alternative treatments. However, since we are focusing on a very specific stage, so the early stage, less than 5 centimeters, then when we are using any definitive measure, either ablation, radiation, or surgery, we are destroying the tumor cell regardless of its histological subtypes. So, yes, so for your question, we did not account into the subtype histologically, but rather as the stage itself.
Okay, thank you.
Congrats to your presentation. Now you are in an advanced phase with your project 1. I would like you to ask you, did you identify any specific patient population who could benefit more from the minimal invasive techniques?
Thank you for your question. This is actually a really good point. So what we saw in the big Kaplan-Meier curve, and I would like to focus on that because this is a really important point. So in this curve, we see the overall survival now. Those are all of the patients, regardless of whether they are high risk or low risk. One of the future plots that we will have would be only those patients which are defined as have so-called high risk for surgery. So there are so-called range in how much patient is well tolerated to undergo surgery, whether if it's relatively healthy without any other comorbidities and completely well lung functioning, to a very fragile and sick regardless of the disease. And in this plot, we cannot see the difference. However, we will produce a difference that we could say, okay, so for those population, those are best respond or the best overall survival for more aggressive surgical technique. However, for those population, those are better response to less aggressive, so like the radiation or the ablation technique. So we will in the future give that information as well. But thank you for your...
And if you let me a second question.
Of course.
As we saw on the overall survival curves, at 1 year there was no difference, significant difference between the three modality, but at 2 years there is a pronounced difference for surgery. And why do you think it is only pronounced at 2 years?
I will say that even not only for 2 years, but also for 3 and 4 years. And that's the reason. First of all, you can see the number of the patient included in the analysis. Comparing to ablation and radiation, ablation has around 300 and radiation has around 2,500. Surgery has the largest. And when we have the largest population, we have the most accurate results. Also, you can see the confidence interval, which is very narrow. Now, I'm very much positively sure that when we will do that subgroup that you mentioned before, we will have a more accurate results. And just for the second curve, the cancer-specific survival, you can see that the radiation and the ablation are overlapping with one another. So this is just the beginning of our analysis, and we can actually see that surgery might not be the best option for all of the patients in every situation. But we will put that part to the conclusion.
Thank you.
I'm just curious, congratulations to your presentation. I'm just curious that what would you choose for yourself if you had this disease?
Ooh.
Because after your background, I think you think that radiation is non-inferior. But after seeing your results, it's clear that it's inferior. So what would you choose for yourself?
So,
or at least for me, I think it's inferior, looking at that graph.
Yes. This is a complex question because I would say that patients that undergo specifically lobectomy, that for them, and they're clinically healthy for that procedure, they should undergo lobectomy. That's my personal opinion. However, when a person has different comorbidities and the so-called malfunction in the lung and other factors that prevent them to undergo surgery, now that's the big question. What will we choose, either ablation or radiation? And based on this curve, ablation is, let's say, non-inferior to radiation. And so for your question, I would suggest that the person that can undergo surgery should undergo surgery. However, as the second line, when a person cannot undergo surgery, that's where we should look more into details.
Thank you very much.